Good afternoon, everyone. Um, First, welcome and thank you for joining us. Today, we're excited to share findings from a national modified Delphi consensus study aimed at developing standardized language for accommodations in clinical settings in medical education. This work responds directly to long-standing gaps in access, equity, and clarity for learners with disabilities. As an introduction, my name is Matt Sullivan, and I'm the Assistant Director for Disability Resources at Washington University in St. Louis, where I work directly with our School of Medicine. I also serve as co-chair and curriculum developer for the Docs with Disabilities DRP Academy. And now I'm excited to allow my fellow panelists to present and introduce themselves.
Hi, everybody. My name is Suchita Rastogi. I am an MPH student at UIC, a former MD PhD student at Stanford University, and the co-founder and CEO of the Disability in Medicine Mutual Mentorship Program. And now on to Lisa.
Hello, everyone. My name is Lisa Meeks. I'm a clinical professor of medical education at the University of Illinois, College of Medicine in Chicago. I'm also founder and co-director of the Docs with Disabilities Initiative, and I'm very lucky to sit on the board of MSDCI.
As we get started, I just want to present a few quick housekeeping notes. First, real-time captioning is available today through Zoom or through the link provided within the chat. Speaking of chat, please use the Q&A function to submit questions. We ask that participants avoid using the chat function as it can be difficult to monitor with a large number of participants. Um, Also, this webinar is being recorded and you will have access to it within a few weeks. Following the webinar, you'll receive a follow-up email that provides you with a direct link to the article we're discussing and to this recording. Sign-up instructions for the next two webinars in the series, details on our upcoming AAMC Learn, Serve, Lead presentation, and a brief 5-question survey. Because this work is grant funded and we're actively measuring impact, we deeply appreciate your time in completing that survey. Now, before we dive into today's content, let's briefly review our learning objectives so you know what to expect and what we hope you'll take away from this session. By the end of this webinar, you'll hopefully be able to recognize the impact of inconsistent clinical accommodation practices and explain why standardized language is essential to advancing disability inclusion in medical education. Describe the collaborative, multi-stakeholder modified Delphi process used to develop consensus-based clinical accommodation language, including the roles of disability resource professionals, students with disabilities, and inclusion experts, and apply findings from the study to institutional practices to improve clarity, support student self-advocacy, guide DRP and faculty communication, and inform continuous quality improvement in clinical accommodations. These objectives guide our conversation today, and we hope they also spark ideas for action in your own institutions. As mentioned, this work was recently published ahead of print in Academic Medicine. The full print version will be available on September 24th, but you can access it and download the article at no cost from the Academic Medicine website. A QR code is available on the slide, and a link will also be sent in the follow-up email. I'd like to take a moment to thank all the authors involved in this paper, including today's panelists and our colleagues who couldn't be here today, Dr. Zainab Danani and Dr. Peter Polis, and Riley Bitchkall. Importantly, we'd also like to thank our Delphi committee members and the DRPs who informed this work, without whom none of this is possible. The DRPs and experts include Grace Clifford, Kara James, Ellen Kaplan, Aggie McGrain, Emily Langham, Christine Lowe, Rosetta Henderson, and Jenny Biggers, and also Jamie Axelrod, Dr. Jan Sarantino, and Sarah Triano.
And the student representatives who participated are Zachariah Khalil, Ifoma Ikedionwu, Pepper Sear, Jessica Campanile, and Nora Newcomb.
As mentioned previously, this article is part of a larger forthcoming supplement focused on disability inclusion in medical education, which is publishing on September 24th. Our panelist, Dr. Lisa Meeks, served as guest editor for the supplement, which features contributions from leading scholars, clinicians, and advocates in the field. We encourage you to read the full collection as it offers a wide-ranging and deeply informative look at disability inclusion across the training continuum. The supplement once again comes out on September 24th. I can't say that enough. We're very excited. And we will send you additional information on items related to that in our follow-up email and other messages.
To follow up on what Matt just said, I'd like to provide some context now about why this work is so important. We're seeing more medical students with disabilities, who we will refer to throughout the presentation as MSWDs. So we're seeing more of them enter training, and this is a very promising positive shift. But despite this progress and the legal protections that apply to these students, many medical students with disabilities face uncertainty and resistance when they request accommodations, especially in clinical settings. So, nearly half of medical students with disabilities report feeling unsupported by their institutions. At least 20% of medical students with disabilities do not request accommodations at all. And among those who do ask for accommodations, these supports are often incompletely or inconsistently implemented. There are several key barriers that contribute to this gap. First, there is a lack of standardized language in accommodations letters, and that creates confusion for faculty, administrators, and learners. Second, many faculty and disability resource professionals, or DRPs, lack experience with accommodations that are specific to medical education contexts. And third, guidance on how to implement these supports in clinical settings is often vague or inconsistent. The consequences of these shortcomings are very real. Learners who are not appropriately accommodated face greater academic challenges, higher rates of burnout, and a reduced likelihood of matching into residency program compared to their appropriately supported peers. This study that we worked on together takes a foundational step toward addressing these barriers, starting with the language that we use to describe accommodations. Now, before we describe our process and our findings in detail, I want to take a moment here to acknowledge those who made this work possible. First, this grant was funded by the Stanford Medicine Teaching and Mentoring Academy's Innovation Grant. This grant supports innovative efforts to advance teaching, mentoring, and equity in medical education. Additionally, four impactful organizations co-led this project, so we also want to recognize their incredible collaboration. These organizations are MSDCI, or Medical Students with Disability and Chronic Illness, DM3P, or the Disability in Medicine Mutual Mentorship Program, SMATI, or the Stanford Medicine Alliance for Disability Inclusion and Equity, and DWDI, or the Docs with Disabilities Initiative. And the reason I highlight these important contributors is to emphasize that this work reflects the power of collective leadership across institutions, across roles, and most importantly, with disabled voices at the center. We're really grateful to each of these organizations for their shared commitment to transforming medical education. We're all trying to shift the needle through inclusion, through innovation, through community, and yet we all bring different approaches to this goal. And so by working together to contribute diverse lived experiences and professional expertise, these organizations really kicked up the strength, rigor, and usefulness of this work.
So, getting started then. The Delphi process began with 9 experienced disability resource professionals, or DRPs, from undergraduate medical programs throughout the US, offering a broad range of diverse experiences, perspectives, and approach to promoting equal access within clinical education. They pulled actual approved clinical accommodations from their own institutions and collaboratively refined this language, ensuring that the final list was grounded in real-world practice and reflected the reality of work related to effective communication and accommodation implementation. In total, 271 accommodations were initially gathered from those 9 medical schools. After eliminating duplicates and items not specific to disability access, we arrived at 89 unique clinical accommodations that were categorized into 6 domains. These domains were adaptive equipment, assistive technology, communication access, location, individualized adjustment/need, and scheduling.
Now, once the DRPs finished assembling all of the accommodations, then 2 stakeholder committees took these accommodations and rated the language used to articulate them through 4 Delphi rounds. One of the committees was a 7-person panel of clinical phase medical students with disabilities. The students brought rich lived experience because they all used accommodations during their clinical rotations, and they had a diverse array of disabilities and other intersectional identities. Their feedback was invaluable. They made sure that the accommodations language was not just accurate, but practical, useful, and reflective of the realities that students face.
There, sorry about that. The second stakeholder group consisted of 4 national experts in disability inclusion in medical education, and their job was to ensure that the language used aligned with best practices in the literature, was legally sound, and was communicated with absolute clarity. Together, these 3 groups formed our Delphi panel. It's harder to do this all at once, isn't it? And for some reason, it's not letting me. There. Okay. So we conducted 4 Delphi panel rounds. In the first round, none of the accommodations reached consensus, and we had to kind of step back and say, what's happening here? And I think for us, what this experience showed us was just how, one, essential this work was, that people were using such different language to describe accommodations, that this work was absolutely needed, and we were grateful to be able to do it. Everybody, it seemed, was using varied language to describe really the same thing. Um, in the first Delphi panelists were able to offer edits and suggestions to give us feedback on the accommodations. So, using this, we refined the language and reduced some of the items on the list as they were deemed either du duplications or they were accommodations that were deemed personal in nature and not actually an accommodation. And this narrowed the list to 75 items. In round two, 65 of the 75 items reached consensus. So that's a huge chunk of the work. In round three, 9 of the 10 items reached consensus, and the final singular item reached consensus in the last and final round. And it's still giving me a hard time.
Thank you, Lisa. Um, for providing that overview of the process that we engaged in consistently throughout the course of multiple months to making sure that we're accurately obtaining both the feedback and putting into writing the consistent and standardized language that we developed. Highlighting the importance of this work, I do want to share an example of a commonly communicated accommodation. So on our next slide, what we'll see is that there is this notion of breaks. And when we were consolidating the existing language from these medical institutions in relation to the work that they were already doing and providing for their students, we were noticing that there was a great deal of variance. Breaks from an accommodation standpoint was being communicated across the spectrum, whether that be breaks for food and drink, breaks for restroom use as needed, breaks as needed to sit or lie down in on-call rooms, intermittent breaks not to impact patient care, or allowance of periodic breaks throughout clinical shifts. So at this point, just taking a brief pause from the presentation component, I do want to open it up to the participants in the audience. In the Q&A function, what challenges can you foresee by communicating a break-based accommodation in this manner? And I'll give everyone 60 to 90 seconds just to jot down some thoughts. We have a few comments coming in. Right now, the theme is centered on timing of there's no length that's describing the timing of the breaks or how long the breaks should be. Lack of specificity. Um, Someone did mention in here if the clinical or rotation is busy, then you may not get breaks. And that is true, especially within rotations that have high productivity standards. Um, the notion of what does periodic mean? Yes, all of these comments are rooted in the same questions and concerns that we even had as a panel of DRPs. Even though these accommodations were being consolidated from our own institutions, it caused us to sit back and think through how can we be intentional about this language in order to make sure that we're not only promoting clarity within the writing, but also promoting understanding within the environment, knowing that when we are promoting understanding to our clinical leaderships or attendings or physicians who are charged with implementing accommodations, we're not only allowing them to understand, but we are empowering them to support their learners with accommodations. In addition, we're supporting the students to understanding fully the parameters of the accommodation that they have been provided so that they can advocate for themselves appropriately. When it comes to this process and going through the iterative nature, we then worked through to open it up for feedback. And through that, the language was consolidated, refined, and finalized to promoting clarity and understanding. So within these grouping of accommodations that we had, it then funneled over into understanding what the core of the accommodation was in reference to. And that was either for pre-scheduled breaks or for unscheduled periodic breaks. From there, understanding that the implementation may be different, a framework of how to communicate the parameters was then constructed and written into brackets within the descriptions. So putting it briefly, for pre-scheduled breaks, articulating that the student would require an X amount or duration of break every, and then frequency of those breaks. Similarly, with the unscheduled nature of periodic breaks, that the student may require brief breaks, then inserting the duration of up to inserting then the frequency or number of times per shift, in addition to any provided lunch breaks. For the unscheduled periodic breaks, it's also articulated within the language that you'll find within the appendice of the study that the DRP or university should also discuss a protocol for addressing extended breaks that impact consistency of patient care, which would potentially necessitate alternative measures. Whether that could be that the student may need an accommodation for absences, which is its own accommodation within the guide. Um, Whether or not the extent of those breaks or absences could then result in a need for a leave of absence for the student so that they can focus on their disability related needs before returning, or potentially the need to repeat a clinical experience in the event of significant infrequency for attendance or engagement that may come up. So those pieces in and of themselves are just two short examples of what the accommodations could result in. Highlighting the feedback loop that we engaged in within the panels, I want to just articulate one accommodation related to priority assignment or placement for clinical experiences. How we presented this information to the panelists who were reviewing and providing feedback was from an accommodation statement and description, as you'll see on the screen. First, it outlines a priority assignment or placement for clinical experiences. And then within the initial description of that accommodation, it stated, given the nature of the student needs, priority assignment / placement may be necessary to allow for appropriate identification of sites with the capacity to effectively meet the student's accommodations. After we submitted that to the panels, we then gathered the feedback that was submitted to us. With this accommodation in particular, some of the feedback that came back through the iterations and the rounds noted that the panelists agreed with the spirit of the accommodation, but they also identified that the description created a perception that the accommodation was optional. And because of that, they recommended revision. So from there, the feedback that we have on the screen is that the accommodation is worded to appear optional, or that the accommodation should be reworded so that non-optional nature of providing priority to the student and their clinical placement in all cases where such an accommodation is necessary is communicated. So we took that feedback into consideration when creating the revisions. That then led us to creating an accommodation that stated priority assignment and placement for clinical experiences, that the student requires priority clinical assignment to be initiated in advance of the standard lottery placement process. In addition to that blanket-based statement there, it then brackets the information that a DRP or university would still need to engage in, that they would need to work in collaboration with the student and clinical leadership to communicate specific accommodation or access-related needs in order to identify accessible clinical sites. So it's both that we wanted to make sure there was more direct nature to the communication that we were putting out there, but that it then led to clarity within the accommodations themselves. For both of the previous two examples, breaks being one, and then also priority assignment, that optional nature or some of the fluff language that could be incorporated into accommodations, a lot of that was reconsidered and removed. We didn't want to put disclaimers on accommodations. We didn't want to promote too much nature of, well, this is what it would be used for. Rather, the goal was to make sure that the clarity was within a direct statement of this is what the accommodation is. The bracket-based information is then regarding more of a process or a procedure that the school and the DRP will need to engage in to promote additional clarity that is case by case and specific for the learner. And then while the previous two were just examples, there is a full list of the 75 accommodations with descriptions provided in the academic medicine supplement that we will encourage you to review further. So ultimately, how does this work assist learners and schools? Why does it matter? Why should we pay attention to it? First, it reduces ambiguity in the accommodation letters. The iterative review process was applied to each of the 75 accommodations discussed within the article to promote that clarity and understanding. Second, it allows learners to educate themselves about what's possible. While this is certainly not a defined menu of options, it creates a starting point. We don't know what we don't know. And the moment we receive enlightenment, it can strike inspiration and understanding of how our needs can be met. And then finally, it supports DRPs and faculty with clearer expectations. It supports DRPs by demonstrating a shared language and modeling the level of specificity needed in describing clinical accommodations. And for faculty, it assists by reducing ambiguity. And for both parties, it provides a basis for discussing what may be possible in clinical training. Moving forward from there, how can medical schools use this information? Similar to the benefits to individual parties, institutions as a whole can use this resource in multiple ways. As a reference when writing accommodation letters, not necessarily as a copy and paste, but as a reference, as a training tool for DRPs and faculty, and as part of a self-assessment to improve their current practices. It offers a robust baseline for what reasonable accommodations might look like.
And additionally, this accommodations list can be a powerful tool for students. So they can use the list to educate themselves on what support might actually look like for them in clinical settings. They can also use that same information to support self-advocacy. For example, they can jumpstart and guide conversations with DRPs and clinical faculty based on how informed they've become by reading the list. And that in turn can help them better navigate the interactive nature of the accommodations process. So these benefits do come with a few caveats, though, and I want to highlight them just so it's clear what the limits are. So the list does represent accommodations that were approved for specific students with specific disabilities in specific programs. For that reason, the items on this list might not apply broadly to all students or to all contexts. But what this resource does do is it clarifies what supports have actually been vetted and used across the country. And this is a crucial first step to empowering clinical phase medical students with disabilities.
And building on what Suchi said, I just want to take a moment to clarify what this list is and what it is not. So, this list is not a checklist to be applied without context. It's not a menu of options that bypasses legal or educational review. And it's not a substitute for individualized decision making. The list can help teams think beyond the status quo, think beyond what you're doing in your individual department and being inspired by what's happening at other schools. It can help reduce miscommunication. So you can look to this list as a guide or a template for how specific, as Matt said, the language needs to be. And it can help people get on the same page when you're doing that by using that consistent, clear language. Now, legally, you are required to engage in an interactive process. Each school is. And this is a collaborative conversation between the institution and the learner. It's how we figure out what accommodations make sense in a specific clinical context, and what the learner may need to remove the barriers. It also helps that the faculty are invested in this process. And here in this visual on the slide, you see a continuous cycle where the DRP is communicating with the faculty member and communicating with the learner, and the learner in turn is informing the DRP if they need any iteration or changes or updates to their accommodation. And that cycle continues until all accommodations are determined and the accommodations are removing the barriers. Now, the faculty bring really important information like what are the essential requirements in this setting? And together, the faculty and the DRP can decide how we balance student need for accommodation and access to the clinical environment. But at a minimum, this conversation should include the learner, who should be centered in the conversation, the disability resource professional, and relevant clinical faculty or program leadership.
So then understanding the need to have more context around decision making, our team has also created a new guide. The new Clinical Accommodations Guide will launch on October 20th. This guide is authored by DRPs, learners, and national experts, and it offers step-by-step support on determining and implementing accommodations within practical tools like conversation starters, guidance on determining disability-related barriers, and domain-specific examples, from legal foundations to drafting letters to supporting DRP and faculty collaboration. The guide is designed to be a go-to reference for building accessible clinical learning environments.
So we said that this is a series, a clinical accommodation series. And today, what we wanted to do is provide you with the science, with the study and our findings, and guide you to the study and to the supplement as Matt suggested, so that you can see all 75 accommodations and you can even see the bridge of where we started and where we wound up. Um, in addition to this webinar today, there'll be two other webinars. So, webinar two will be when the guide launches on October 20th. And the guide, as Matt mentioned, is going to provide a lot more context to people about how we make these decisions, what's required. So it will be kind of wraparound support for the 75 clinical accommodations, if you will, with new and updated information and new findings that are coming out in the research. So webinar two is standardized clinical accommodations, releasing the new guide. And webinar three is the accommodations guide, implementation and infrastructure. And in webinar three, in that particular webinar, we're really going to focus on leaders and those that are budgeting for accommodations, that are implementing accommodations. And how do you do this proactively? And how do you make sure that your clinical learning environment is running smoothly? So these are October 20th and January 21st. And the link to those are on this slide, but also in your follow-up letter, the links will be there so that you can register. On November 3rd, as Matt said, we will be presenting this on a panel that includes student affairs leaders, DRPs, students, Matt Sullivan. And this will be a panel about how people are using the guide, what the guide is, how people are implementing it in their schools. And we'll have some interactive discussions about how it might be used to support leaders and faculty. And that's on November 3rd at 3:30. And so we're going to take questions, but I do want to thank all of the individuals who came together to design this study, to implement the study, to get the funding for the study, and then, of course, to help us disseminate the findings. Again, the paper is in academic medicine, and a wraparound full context guide to provide you with more support will be available on October 20th. As Matt said, our work is funded, and our funders want to understand the impact and the value of the work from you. So we ask that I did add one question, Matt. Sorry, it's no longer five questions, it's six questions, because we want to know what is most impactful from each webinar for you. So, quick six-question survey. One of the questions is, what do you do in your organization? And then we're happy to take your questions. I will say, webinar number two is specific for DRPs. It's kind of tailored to DRPs to help them make better decisions, understand in the context of their work what they should be doing to both make a determination for clinical accommodations and to communicate what they have determined is reasonable and how they should be working with faculty. And then webinar three is really geared towards leadership and faculty that are implementing those accommodations. And we're happy to take as many questions as you have. We wanted to leave lots of time, which we're 3 minutes over the time that we targeted. And but what we can't answer for you, especially because we're recording this session today and it will be available for all, is we can't answer questions specific to cases that you have at your schools. Please try as much as possible to anonymize information, and you can ask questions anonymously. So I'm going to take the slide down so that we have full view, but you can see here our information about how to contact us. And we're really glad you joined us today. So I'm going to field the questions, and these two amazing leaders are going to help answer them. So let's see. These were all of your guesses. Let me get to the first question. Excellent distillation of the complex needs associated with disability accommodations. However, even if only one accommodation is needed, let's say a schedule, to protect and preserve the health of the person with a disability, it may not only be repeated, but may be used as a point of vulnerability to deliberately further worsen the health of the disabled person to the point of not being able to work full-time again. The main thing persons with disabilities need is um, an attorney, incorruptible attorney as an advocate. Well, and hopefully our work is making more of a impact and everybody won't need an attorney. But I do, someone said something to me the other day that really struck me, and that was, you know, it's, they were talking about use it till you lose it. And with so many people not disclosing disability and not getting accommodation, the tendency is for these the physicians in training to come in and push themselves to the point of actual damage when they have chronic illness. And because they're fighting so hard not to have to say that they're disabled or not to have to ask for accommodations. So I happen to know that Suchi has some both personal and professional experience in this. And so, Suchi, do you want to respond about perhaps why we need to address this even more so that people don't need legal counsel to get the accommodations that they need?
Yeah, I think that, a lot of the time when accommodations are challenged or not taken advantage of for whatever reason, it's from a lack of information. I think that's probably the biggest reason. So, first, the learner or the professional or the trainee with a disability might not understand what's actually available to them and will ask for little or minimize what they request so that they're not this squeaky wheel and appear more amenable to their colleagues and their superiors. And that can feed into pushing yourself way too hard. And I was definitely guilty of this. But the other side of the coin is for implementers and for faculty. If they don't have the information about what's possible either, they won't know, how can accommodations be appropriately implemented so that it creates the least amount of strain. And they might be coming from a very good place and saying, hey, I want to help you, but they provide maybe inconvenient ways of helping or ways that would work really well in practice, but just don't know how to implement it. So that's the other thing. And to step it even further, to address your question or, your, I guess, kind of the heart of the question, I think, is there some people who really don't believe in disability inclusion? I would argue actually that providing this information does elevate disability inclusion even to those people because they see kind of the vast array of what's possible. And now that these accommodations are vetted and they're seeing, hey, they're being used at other medical schools. And, we haven't released the names of the medical schools, but clearly we selected schools with a vast array of funding situations, whether they were public versus private, and that's all listed in the paper. And so that grants legitimacy to these needs. And so then hopefully people won't have to fight as hard in order to have their accommodations honored, even by those people who might not understand disability inclusion as well.
Thank you, Suchi. Yeah. And the fact that there was so much duplication also tells you something, right? That so many schools were submitting the same types of accommodations. Um, Matt, the next question is for you. This is such great work. Kudos. Synthesizing what has emerged as novel expertise and prolific work in the field of accessible medical education. Something I'm thinking about is succession planning, which I think we should all be thinking about. That's excellent. As someone who has been following along and learning in real time with all of you since 2017, I would love guidance on how to introduce the learning and guide to future DRPs and guide future DRPs in their learning in a sustainable way. Well, Matt, that is right up your alley.
Seems like a bit of a loaded question, though, if I'm being honest. I would say that this is a team sport for sure when it comes to succession planning and the promotion of equal access and inclusion within our field in its totality. One aspect that I would promote selfishly is the DRP Academy, which is designed as a comprehensive training program for DRPs working specifically in medical education, knowing that there are intricacies and nuances associated both with the didactic learning components and with clinical learning components that far surpass what we know as equal access within a standard undergraduate 4-year bachelor's program. So one would be that continuous nature. And from that DRP Academy, we are working to making sure that that information and that content is more widely available. So from those pieces, there is this constant desire to making resources available because we know that one specific platform may not reach all the individuals who need the information. And that goes for both DRPs and for learners and for faculty and program administrators. We want to make sure that this is as widely available as possible. So not just having these documents and these articles in stagnant locations. Rather, we want to promote a nature of living, breathing information that's constantly evolving. As we know, both access and what it means to promote equal access is evolving and enhancing, but also our learners are evolving and enhancing with their capacities and how they approach medicine. And because of those new and varied perspectives, we get diversity of thought both within the educational setting and within the practical setting of medicine. So there is more to come. I'll leave it at that, as vague as it may be, but there is definitely a way that we are promoting a long standard of making sure that this is sustainable content that is out there and available for all.
And and Matt can be a little bit more coy. I'll be a little bit more direct in that we have developed competencies for specialized medical education professionals where there are no competencies that exist. So who is doing this job? Even if we're touting that this is a necessary role in your medical school, who is actually performing the job duties and the tasks? And so I want to encourage you to read another article in the supplement by Sarah Triano about the value of specialized DRPs. And then Ms. Triano will be, along with Dr. Sullivan, will be publishing more work on competencies for these individuals. And then that pathway has been established. So we'll have more work to support medical schools in the future. Another question is, does the guide, so I'm assuming, I'm going to make some assumptions in the questions because I can't tell. So if you wrote the question, feel free to correct me. Does the upcoming guide include information on technical standards and essential functions based on area of study? So I'm assuming this is talking about GME. If yes, how is it developed? Or it could be talking about clerkships within UME as well. So Matt, do you want to speak to what the guide includes? The upcoming guide.
Yeah, so the guide will be using the 75 standardized accommodations language as the groundwork. But in addition to that, to make sure that we're setting the stage for the information within, we are kind of walking the readers through start to finish. What are the foundations of the work that we're doing? How is that rooted both in legal precedent and frameworks, but also how is that rooted in the need for access and inclusion to ensure our learners are representative of the population they're supporting, to making sure that we're actually paying attention to that component of what is disability access. Um, so from there, the guide in and of itself, while is being written and framed by practitioners within the field and also scholars within the field who strongly promote this nature of disability as diversity, disability access and inclusion being integral to the work that we do. We're also approaching the guide from a standpoint of knowing what are the foundations of what is necessary, what is compliance, and allowing us to identify what is that floor so that institutions can align it with their personal values as an institution to saying what is the ceiling when it comes to promoting access. Our goal is to making sure that individuals have the tools within their toolkits within this, since to saying like, here are the 75 accommodations we know exist, but we need to adopt these to our own institutions. And how can we do that in a manner that's not going to compromise our educational standards, but also is there then a way that we can make it work in some way, shape, or form to promoting that equal access and welcoming environment to all students?
And then, Matt, there was a follow-up question about undue burden and and whether or not we contextualize this in the guide as well.
That will be touched upon.
Edited, I am going
Yeah.
to say yes.
Yes, that will be touched upon. So, in general, an accommodation is unreasonable if, for one of those reasons, is if it promotes an undue burden, and that is financial or administrative. So, that's going to be discussed within the guide. The nature of what is a financial undue burden and what is an undue administrative burden, that will be a case by case determination for each individual institution. However, those components are going to be discussed as well as the components of an accommodation being unreasonable if it compromises patient safety, if it substantially alters the manner in which a curriculum is delivered, and whether or not it may present a fundamental alteration to essential elements.
And I will say, I know Dr. Sullivan, for both of us, we have done that evaluation and have found things to be unreasonable. I think that when you are working with specialized DRPs, I see a lot of terms about advocacy. I think that uh, ed, most trained specialized DRPs are truly providing a service that is a neutral party. So they're both an agent of the institution and working for the institution. And it's kind of like translating what is required legally and in other ways to the institution to allow for access. But I think that the idea that most DRPs are simply making decisions regardless of the impact on the institution is probably outdated, at least with the DRPs that I've been working with. They're uh, just very, very sharp individuals with a good command of how to make a balanced decision. And could you provide, actually, Matt, you might be able to do this. Could you provide an example of an accommodation that would pose an undue burden and would be denied? And it's interesting, right? Because this would have to be just it would unfortunately be a generalization, which we tend not to do because everything has to be determined in context. But I wonder if there's something that's so absurd that, and I'll give you a minute. I will say that the first of all, undue burden has never been successfully fought in the courts, so we don't have precedent in medical education for what an undue burden would be. So anything we would say would be kind of a guess, but I can tell you that interpreters at a cost of upwards of $300,000 a year was not burdensome, determined to not be burdensome by the court.
Yeah, when it comes to the unreasonable nature of accommodations, I'll do kind of a compare and contrast of ways an accommodation may be reasonable versus unreasonable. This is a complete hypothetical, but for that situation, a student may request an exemption from night shifts. Um, and in some ways, that accommodation, what you'll see within the guide itself, there's an accommodation that's noted as rotation schedule continuity. And that in spirit is indicating that student needs consistency within their schedule to, I mean, the spirit of it is to manage disability related symptoms and to make sure that they are holistically identifying and tailoring to their needs while also balancing that clinical expectation and schedule. So the description of rotation schedule continuity is that the student would require a consistent clinical schedule. And when this clinical schedule rotation requires a schedule change of 8 to 12 hours difference, so for example, a day shift adjusting to a night shift, that there would need to be X number of days for that adjustment period. So within the continuity, it's not to saying that a student is unable to participate in night shifts. It's stating that there are parameters necessary to ensure they have access to engage in that opportunity. So they would need this buffer period in order to then make the adjustment themselves to safely transition that schedule. That is reasonable. When it comes to something that may be unreasonable, is if a student said, Well, the schedules are really demanding within the clinical settings, and I know that my sub-I is coming up, and I have a period of 2 to 3 weeks where I'm just constantly on the clinical wards. I really think that I should only have to participate in 2 or 3 days a week because I think I can learn the material enough within those 2 to 3 days instead of participating in the 7 day work week shift. That in and of itself would need to go through a more thorough review that would involve your administrative partners to understanding, okay, we do need to go to the basics just to make sure we have a very strong foundation. Are what are the core pieces that we are trying to educate students on within a sub-I? What are the expectations? What are we hoping they learn? And what are the outcomes associated? Then let's identify and understand the structure of the sub-I to saying, okay, if these are our outcomes, how are these outcomes actually taught and learned within this scheduling sequence? Then to identifying, is there any type of wiggle room, whether that be with the hours that are expected, the productivity standards, and everything else that's associated? Most of the time, a program will be able to have those details readily available. But after you've been able to set the foundation and understand those core components, I'm going to, in this hypothetical, lend to guess that reducing the number of days expected for the work week to 3 is going to be unreasonable, primarily because it's going to disadvantage the student and be detrimental to their access of actually obtaining the learning outcomes, but then also identifying what are those alternatives that can be implemented that may be reasonable. It may not be that 3 days a week, but it could be some notions of whether that's breaks, whether that's need for more continuity or consistency, whether that might be an exemption of night shifts potentially. But there are many options and varieties, which is why I will always caution institutions to keep some of their thoughts of, well, that's a fundamental alteration kind of to themselves until they actually know that it's a fundamental alteration to the curriculum. We don't want to cry wolf in these situations because we can actually sell ourselves short. We can sell our faculty and administrators short because typically when I've engaged in those processes, I've had a lot of really great conversations from innovative and creative educators who have said, well, that and its current request format is going to be really difficult given our structures. However, let's explore X, Y, and Z options. And through that exploration process, we're able to come together to create an understanding of what's possible so that the student is supported both with their disability related needs and to ensure they're getting an equal education as their peers.
And I think the example you gave, Matt, is a great example. The sub-I is where I've had a lot of issue, and that the expectations for the sub-I, and there's a question about GME and whether these accommodations apply to GME. So I'm going to make some statements in kind of referencing into this question, but the sub-I is a different set of expectations and a different set of learning outcomes. And even within the same training institution, within undergraduate medical education, the accommodations that I've approved for, year two clerkship experiences, year three clerkship experiences, and then sub-Is are vastly different and holding to the expectations that are in the sub-I. And I know personally I've never created an accommodation that's undermined the rigor or the breadth or depth of the training program. I think most people who have that advanced training would not do that. Another accommodation that I've denied, and I say it because there's another question about this in the chat, the fully remote curriculum. That is, of course, we have to go through a full process, and as Matt knows, and as you'll know as you work through the guide, you have to document that process. So it's a very, very formalized process to say that something's a fundamental alteration. But in a case that I worked on as an expert, we determined that that would be a fundamental alteration of the curriculum to have a fully remote process. But as Matt so elegantly pointed out, you do need to respond with what is possible. And so being creative in that space, what portions can be remote? Many of you deliver portions of your medical education remotely. And so what can be done, even in the context of a denial of an accommodation that was asked. Suchi, I want to go to you really quickly. The We have a learner in the webinar that's asking about whether or not you think the pathway, if there's things in the pathway to medical school that are keeping people from even getting to medical school. Could you speak to that for a minute? And then, Matt, I'm going to circle back to you with that GME question, which I think will have to be our probably our last question.
Yeah, so I might not get everything because when I applied, I didn't know I had an illness. Um, but just from what I've heard other people say, the accommodations process is not very transparent when applying to programs, and whether to disclose a disability and how to go about that process is very difficult. Some may have been counseled, hey, here is what medical training will be like. You're going to be put through the ringer. You'll be drinking out of a fire hose. And then there are all these physical demands that will be placed upon you. I don't think you would be suited for it. And so many people are kind of turned away. I'm hoping that with the release of this list of accommodations and other resources that Dr. Meeks and Docs with Disabilities are coming out with, it will be more and more apparent to advisors in undergraduate, not medical education, but true undergraduate college education, that there are a lot more possibilities. There is flexibility. It's not that people have to have X, Y, and Z organic features of their body in order to practice medicine. So that kind of awareness building will hopefully break down some of those barriers. But those are some things that prevent students from getting in. And then kind of thinking from a public health perspective as well. Students with disabilities have a lot of kind of epidemiological characteristics that sometimes can be barriers as well. And that might include lower income or, extra costs associated with having a disability. And that might make them say, hey, I can't afford medical school or health professions training because I have to pay for my medicines. I have to pay for my durable medical equipment. So those are just a few things off of the top of my head that might prevent someone from applying. Those who do end up applying and then are in the process of interviewing might face other barriers, again, related to accommodations, that might make them say have to cancel in the middle of their interviews if some sort of disability related need comes up that isn't accommodated very well and therefore sabotages their interview or something like that. But that's what I can think of, and I'm sure that there are other barriers, but hopefully with this type of education it will continue to push the needle to make sure that those barriers continue to be broken down.
Thank you, Suchi. There are a couple questions I just want to respond to quickly. Will we have access to other articles? All of the articles for the supplement are out in preprint. So those little last minute edits, preprints always me because there's always the little last edits that go in there. But it is out and it's available on the academic web medicine website under in preprint or something like that on their page. And I'm going to recommend, before I pass this to you, Matt, that I know there was a question about what a sub-I is. If you are a DRP, and this is not your area of expertise, but you want it to be, please go to our website and download, look under resources and download our DRP medical school terminology guide that gives you the ABCs and one, two, threes of the words that we use in medicine and medical training. It's a lifeline for you. And then, Matt, do you think the unification of terminology around accommodations will open up a discussion to improve technical standards in GME? And there was another question about GME. Can the guide be applied to GME as well as UME? There are concerns about providing UME accommodation at times because they may not be available in GME.
Short answer, yes. Uh, Long answer, which I'll try to keep brief, is access within educational structures and training is a bottom-up approach. The more we start to implement and refine and actually effectively promote these structures within the lower levels of education, the more students will themselves understand how they can balance and navigate not only advocating for themselves, but navigating the clinical environments while utilizing accommodations, which will only promote reassurance to attending physicians and others within GME to understanding, oh, this isn't something that's scary and ambiguous. It's going on in UME, and I have these learners and these residents who are pros at implementing them. They just need to make sure that it's documented within their system so that the learner has protection. So they know, nope, this I need to have a pre-scheduled break at X time in the morning and X time in the afternoon. As long as I have that, we're all good to go. So that then helps promote that reassurance and the understanding that this is possible. But it is difficult to saying it's a top-down approach because that's not the case. So I can understand why, well, GME might not provide it. Well, of course, they don't even know what's going on within UME at this point. So the more we promote that education now at this ground level, the more it will promote understanding at the next.
And interestingly, well, first of all, ACGME is launching a very big project next week, which is called the Disability Hub, and it has a UME to GME transition guide for faculty, staff, and learners. It has a policy guide, a policy toolkit, and it has case studies of what's actually happening in GME that the average PD is not going to be aware of. But of course, there are differences in GME. The expectations are different, the requirements, the essential functions of the job are different. I think the best thing you can have is and I know I sound like a broken record, but a qualified specialized DRP who understands GME and the GME landscape and can guide the learner to say, this is what we can do at this level because this is reasonable. At this level, depending on your specialty, this is what may be considered unreasonable, and you need to make decisions for your specialty choice, for your program characteristics, based on having really good data, really good information about the differences in the law and the differences in UME to GME. So, having educated mentors and educated DRPs on that transition is imperative to helping make a really good transition. Well, we are over time and we're so grateful to all of you. Thank you so much for joining us. Again, webinar 2 and 3, highly focused with more information. And we look forward to seeing you. Please join us in our goal to make more accessible education in medical education and other health professions. So thank you so much. And we hope you have a wonderful week. Many of you are starting your new classes. So congratulations and may it be a smooth transition for everyone.